mean, we have to make sure that we really do healthcare delivery no matter what lines of business it is, commercial, Medicaid, Medicare. In those all cross lines of business, there's standardized care that needs to be delivered equitably and equally, both on all premises. But there are specific things that you do where the most vulnerable population like Medicaid, we need to consider some things that we do differently, because not every Medicaid member is going to come into a brick and mortar and have their care delivery done at a provider office. So we have to think creatively and how to reach this population and be able to deliver care where they're at, Chris.
That's Mary Walter about to go in deep on the business case and the ethical case for healthcare leaders to focus on Medicaid. This discussion is the first in our ViVE series, which highlights impactful conversations at the ViVE Healthcare Innovation Conference. Mary is Managing Director of Quality and Accreditation at Health Management Associates, commonly called HMA. Mary's background includes leading managed care at top 10 insurers, as well as providing care one-on-one as a nurse. So in our conversation, Mary focuses that expertise on creating better outcomes and experiences for people who are enrolled in Medicaid. Additional note, Medicaid redetermination, which may cause 15 to 25 million people to lose their Medicaid coverage, is well underway as of April 11th, 2023. We refer to it as an upcoming program because we recorded it slightly ahead of that time. Thank you for tuning in to Meeting of the Minds, and we'll jump right into it. All right, so we are here at ViVE 2023 and really excited to have a conversation with Mary Walter today, who is the Managing Director for Quality and Accreditation at HMA Health Management Associates.
Thank you, Chris. I'm so excited to be here, and I think we have a lot to talk about in terms of innovation healthcare and this topic alone. So let's rock and roll.
Fantastic. And when we're talking about this topic at hand, what we're addressing is like, if you're at this conference, it's an innovation conference, but we're hearing all about payment reform, alternative care models, and things like that. And what we wanted to discuss was one of our most vulnerable populations, which is the Medicaid population. We know that there's a lot that impacts our most vulnerable populations. And what we actually got this hat a little bit earlier today. For those who are not looking, it says Healthcare Optimist. So what we want to talk about we want to be very frank and very real about the challenges that face our Medicaid members and vulnerable populations. But we also want to talk about the things on the horizon that you as healthcare leaders and innovators can do to help and work along with this population. And let's not limit our thinking after this conversation to just our Medicaid population. Health equity issues impact people across the board, under commercially insured, uninsured, across the board. But the types of things that we think about for this population, the types of things we think about even in terms of building a business case for addressing these health equity needs, can apply all across the board. Am I right? Or
You're right on spot. I mean, we have to make sure that we really do healthcare delivery no matter what lines of business it is, commercial, Medicaid, Medicare, and marketplace, and other community-based organization like safety net facilities and organizations.
Thank you. And for those of us who might be, there might be some people on LinkedIn like, who's Mary? So what drew you to Health Management Associates?
What attracted me to Health Management Association is because it was truly diverse. So for example, Chris, we have a strategic focus area, not only in the area that you just said, my title, accreditation and quality, but we have justice systems, we have behavioral health, we have regional Medicaid managed care, we have Medicare, strategic focus area, we have delivery of service, we have IT and technology right here, and we have so much more. We have 15 different strategic focus areas. And so what made me excited about Health Management Associates is that I would be able to be a part of this amazing team to help our clients out there truly transform healthcare in all the topics we talked about today, and getting ahead of the curve around health equity, around Medicare Stars, around Medicaid and innovation, around all of these areas that I just described. There's a lot that we do, and it fits my passion around how we can impact the delivery of care. So this is why I came to Health Management Association.
Well, that's
Associates.
that's a great story to tell for people who maybe they're at an organization that they don't feel is delivering on the types of impact that they're focused on, is to have that standard and have that understanding of looking, does this organization align with the change that I want to bring?
And it does. And I get to work on all these amazing, amazing projects in the realm that I just described. So very excited about the future and where we're headed as an organization.
You bring such a rich background, having led efforts at our top insurers and now going into HMA. Could you talk about the things that have led you to focus on this vulnerable population? Like what in your history? Let's relate it to the personal background on why you're here discussing what we can do for these populations.
Well, Chris, my history goes back to when I was 4 years old, and I was actually adopted from Korea. And so I came into the United States very, very sick and very ill. I had tuberculosis. I had major skin ulcers and rashes all over my body. My hair actually felt like a horse's tail. Now think about healthcare in Korea in 1967. Think about when I was born in 1963, those first 4 years. I didn't have necessarily healthcare. The way I came to the United States is that all of a sudden I had equitability and accessibility to healthcare. My family was not very well off, but they knew that they had to get me healthy. And so I was able to get the treatment and timely, and I was able to resolve all of those issues that I've had. And I think about that access to care, that ability to have the type of healthcare that I needed to heal was really, really important for my survivability. Because if you know anything about tuberculosis, you can actually die from that disease, and very quickly as a 4-year-old child. So I was in a pretty critical care condition in terms of outpatient care and almost hospitalized because of a result of that. So then I think about when I was growing up in the community. I was probably the only Asian in a very small rural town in Iowa. And my parents could see that my ethnicity, as well as how I would adapt to that community, was going to be a big climb and challenge for me.
Thank you. Thank you for bringing up your personal history and the background on the equity and care issues that you've faced. Like just given background as immigrant status, Asian, just being in this particular community, it addresses a topic we've discussed before on this around intersectionality. One thing I'm wondering, because we built up the conversation talking about innovations available for vulnerable populations. For the folks listening to this, what's key that you think that somebody should come away from this conversation with?
The key is really to think about every person in the United States that deserves health care, and that deserves it in a way that will keep them healthy. And if they're not, that they're able to get the care that they need specifically for their condition, like for myself, for example. And then think about this. In 2044, the U.S. Census states that the racial ethnic minorities will be the constituents of the United States. So let's do that proportionally in your mind in terms of future cost. The other thing is 10.6%. This is what really grieves my heart. African Americans, don't have any insurance, but yet white people, 5.9%. So half of that. In addition to 21.5% Hispanics are diabetics 20 years and older, but yet the white population is 13% in diabetes, Chris. So you can see the disparity right here in terms of just the statistics that I'm quoting you. And then the other thing that really grieves my heart is that 94 million coming up on April 11th will have Medicaid redetermination. What does that mean? That means they're going to have to show evidence that they are Medicaid eligible to stay on the plan. And there's a prediction that 20 to 25 million will lose coverage. Now rewind. I'm 4 years old. I'm a Medicaid child. I deserve health care.
Absolutely. And when we think about the redetermination effort and just the risk that you said 20 to 25 million people.
Approximately is the prediction.
Yes. So losing access for things that are certainly not crimes, such as like having moved and not receiving the communication around reactivating, that's a major challenge that our Medicaid population faces. And I'm just like you brought up a lot of information on disparities and the differences that among these populations. One thing I'd like to do is just go all the way down to the basics, because a lot of people watching this, like even though we have an audience of healthcare innovators, I want to make it accessible also to people that are coming in. Can you talk about like who the Medicaid population is and other risks that make this population vulnerable?
Absolutely. So, when you think about the Medicaid population, you think about women's health, you think about children's health, and you think about the population that is at risk. So I think about the African American woman that has the highest risk in terms of mortality and morbidity, in terms of OB risks and delivery. So that's something to pay attention to. I think about the child that has specific special needs, the disabled child. I think about the child that has, specific conditions and diseases that they deserve to have equal and equitable care. And I think about the deaf and hard of hearing, anyone that has challenges around their health and challenges around getting that health and getting the right kind of care and truly having a quality of life. These are the individuals that we're talking about, women and children specifically.
So we're talking about something that exists as a safety net for people that are in extremely vulnerable scenarios, like you were talking about, women, children, disabled, and many other aspects.
Absolutely. And we can't forget behavioral health, because behavioral health is an integral part of every individual, from management of that individual to population health management. So you can't separate physical to mental health or behavioral health. They are very integrated. It's whole person and population health, and it must be coordinated, it must be integrated, and it must require a cross-functional team to be able to bring the delivery of care that each and every single one of those individuals deserve.
And of course, when we think about our populations under these mental health aspects, and when you think about the integration and coordination that is needed to start addressing these issues, especially when we think about the upstream impact that mental health might have on downstream physical health issues, and how those costs are seen. One thing that again, we've been talking about payment reform a whole lot. We've been talking about various innovations. Can we talk about the business case that people in healthcare organizations might have to make to address these Medicaid populations sustainably? Like, what do you see on the horizon that might be helpful to generating that business case to start focusing more on health equity?
I think, when we take a look at programs, services, products that are being developed with, managed care organizations, value-based purchasing with our providers, with our hospitals, with the healthcare delivery system, we have to think about making it easy for the members and making it easy for the providers. It does not need to be complicated. I'll give you a perfect example. In terms of this Medicaid redetermination of all of those individuals that have the risk of losing healthcare coverage, in fact, they will lose healthcare coverage. Whatever we are offering, let's say I have 25 years of managed care experience, that we invest in the community-based organizations, we invest in these programs, we invest in technology, we invest in the ability to reach these individuals. And in that same mindset, when they lose coverage, why not enroll them in Marketplace? But if it's Marketplace, Let's make sure that we have that same investment in the community organization, the same investment with the providers, the same investment with those partners that are providing that delivery of care, including behavioral health. Because here's where the disruption occurs, Chris. When they go from one lines of business to another, all of a sudden, if that doctor isn't in the same network between the two lines of business, that's a disruption to care. Think about the programs. If someone is Hispanic, is in a diabetes program, and all of a sudden they change from a different line of business and they don't have the same diabetes program, or they have to re-enroll in something different, that disrupts continuity of care. So that's simple, right, Chris? It should be. If we think thoughtfully as leaders, that when we design and transform healthcare, let's think lines of business agnostic, let's think payer agnostic, let's think provider agnostic.
I mean, that brings up a really powerful point, because a lot of what we've been talking about is around payment reform, but what about the internal, like what you're bringing up is process reform around making sure that people don't have these unnecessary barriers that get erected and disrupt the continuity of their care.
Absolutely, because I think about the providers that are out there, and when there are different programs for different managed care organizations that have a lot of variation and differences. Imagine trying to manage 6 different managed care programs in one single population, meaning from birth and even pre-birth, if you really think about healthcare and in terms of the unborn, having healthy babies when they're born, and then all the way to end of life. There are some things we can do to standardize some of those programs, still keep proprietary, where proprietary is to serve, but there are standard best practices out there from a clinical medical evidence base that can dovetail to a payer agnostic type of programs that can be a win for the member, for the provider, for the community-based organizations. There's got to be a tie into that as well. And then pharmacy and behavioral health, all of that in concert and working cross-functionally to be able to make it easy for the providers. I have a perfect example. Do you want to hear about it?
Absolutely.
All right. So there was a teen screen program where I worked in an integrated delivery model, and we decided to use Columbia University PHQ-9 tool. We added 2 suicide questions. Does the member have a plan for suicide, and are they going to go through with it? This was a payer agnostic tool, and it was rolled out in a particular market as a pilot. And Chris, the pediatricians were pessimistic about it at first, but what they discovered is they could screen across their entire population. It was payer agnostic, and it identified risk, and actually through data and be able to look at the suicide rates per 1,000, they actually decreased per 1,000, Chris, and screening went up. The pediatricians were elated because they could do population health with a simple tool, and that we made sure that there was clear coordination between IT system and process and people to be able to ensure that medical to behavioral health coordination was intact, whether it was routine, urgent, or emergent. We had the safety net processes and services to back up that program. It mushroomed and it grew nationwide.
So that story is really powerful because it focuses on some of the business process aspects that you were focused on. And you said payer agnostic a lot. I wanted to say that more so that it sticks in our audience head even more. And also, it focused on a data innovation, capturing information that allowed healthcare providers to be able to act. One big question that I have...
Wait. Can I add one more thing?
Please.
Here's the cool thing. In that program, there was a win for the other payers because it was not only making a difference for this single payer, but it was making a difference for all the payers that provider was managing the care and being reimbursed for. So it was really a win-win for everyone.
Oh, and could you elaborate on how how that win happened, how it created the win for multiple payers within the network?
Yes, because we had a little, we know each other, right? So there was evaluation from the pediatrician's offices that said that not only were they pleased with this particular payer that I work for, but that they got feedback that they were going to go ahead and do this for the entire population, and that they went to the other payers and asked what was the value add to this. And the other payers said, huge value add. We're not going to stop this. This is a great tool to be using for the entire population. So it was a win.
I had to ask you to elaborate on that one because the stories that I want people to hear are the ones that focus on sharing, getting out of the silos, and having communications with those that are our competitors in business spirit, but still being able to focus in on patient needs.
Yeah.
And it just leads to my next thought, which it's really tied to this one, is in terms of digital innovations that can help with our vulnerable populations. Can you talk about other digital or data innovations that that you're eager to see people adopt, or if there are other stories that you might have?
Well, I think the COVID pandemic really got us to think not brick and mortar anymore, but how do we bring care to the member and where they're at? So I'll describe it in two different ways. The traditional way that we think about telemedicine is to be able to be it by phone or it could be virtual on the internet. Those are two different quote unquote telemedicine approaches. But let's get creative with the Medicaid population. One of the things that I think is very important is been sharing a lot is how about free clinics or clinic opportunities in the schools? The children are already there. This is the most vulnerable population. Why not partner with the school systems? There's a school nurse, and that representation is within the school systems. And so collaborate with them. Collaborate with the Boys and Girls Club. Collaborate with the YMCAs out there. Any community organization that's present, there isn't any reason why we can't deliver care there. Some people will say, well, immunizations have to be refrigerated. All right, so mobile ban, put it in refrigeration, go to the Girls and Boys Club, do all the risk and legal things that you need to do to be able to run the program, but deliver the care there. Why not? Because that's where they're at, and they're not always going to come into a brick and mortar clinic office. And by the way, you remove the barrier of transportation. You remove the barrier of inconvenience or whatever the excuse is. But we have to think thoughtfully about taking IT and technology to where the members live. And by the way, Chris, you don't know this, but my grandfather was a doctor. He did medical care in the home. And we have been returning to that, obviously, in the last few years. But let's think about home. Let's think thoughtfully about innovating ways to be able to reach this population without always having them come into a clinic. Now, obviously, if it's urgent, if it's emergent, this is where my nursing hat comes in. Then we have to make sure that transportation and all the other things that those members need are going to be able to get there timely, whether it's urgent care centers or 911 emergency.
So, and I like the way that you bring that story, because to think about where members and where patients are, it's really a merging of data strategy that result in a delivery strategy. So it depends on not just looking at entire population results, but looking at these subgroups and identifying where they are and where those opportunities might be to better connect with those endpoints in the community.
Absolutely. And I think there has to be a coordination. Providers need to know what these community-based organizations are. I mean, those clinics that are in the community, they pretty much know. But what I'm saying is the coordination between provider, community-based organizations, the health plan, and any other partners that are part of that coordination, that communication has to be streamlined. And it has to be streamlined through the various systems that that member is experiencing, from that point of care to capturing successful quality metrics.
So one thing that that I wonder, just based on like in our conversation, we know that most of the people that, especially in your days in nursing, wanted to do good for patients, and like I can't think of anybody who is out there actively trying to cause harm to entire populations. But we have been slow to adopt solutions that help our most vulnerable. Could you talk about some of the barriers that organizations are facing to be able to address the needs of these populations?
I think it's really just around understanding who the population is. I mean, I think oftentimes in healthcare, we develop this wonderful model of care, this transformation of care. We work with our providers, we work with our community-based organization, and we think we have the answer. But did we ask the member? Is that something that they want? It's interesting, I have two examples. In one of the organizations I work for, we actually developed what we thought was the most amazing transformation of care. We pulled in some members and we asked them what they thought. They said, that's not quite what we want. So it goes back to that tree diagram. I just want a tire and a rope, but you gave me 10 different ways to deliver this care, and I'm not looking for those other areas. I'm just looking for the rope and the tire. Mm-hmm. And I think we've got to get to simplicity. The second part is there's a really good breast cancer screening project that I was very much involved during my Lean Six Sigma training. And I just decided we're going to ask our members, you know what? Why isn't it that you're not getting a breast cancer screening? Help us understand. And they said it wasn't because it wasn't important. They understood the importance of it. Okay, scratch that one. I know it's painful. That's not the reason why I'm not getting a mammogram. I mean, all the reasons that we in healthcare delivery thought were reasons why they're not getting a mammogram, they said, you know what? Your incentive isn't high enough for me to be able to, in the Medicaid population, a lot of women at that age are taking care of their daughter or son's children, grandchildren. So therefore, I have to hire a babysitter. I've got to take that inconvenience of no money for food, and yet there's $25 is not going to cover food or babysitter. Your incentive's not high enough. We said, well, what would do the trick? They said, you know what? If you got it up to $50, I think we would consider that. Do you know what, Chris? Our breast cancer screening rate went up, and it was statistically significant across the population. It was that simple. We don't ask our members. The voice of the customer should be our primary source to do the model of care development and the voice of our providers.
Thank you for aligning that. If someone was to, if someone listening, what was to start breaking that down, they heard earlier in the conversation we were talking about data to identify the subgroups and populations in need, but that's not enough. Just knowing who it is and even developing a plan for them internally is not enough until you start listening to their voices.
Exactly. And I think, I'm saying every healthcare worker, every individual that wakes up every day wants to do the right thing. We all do, and we do it with great and positive intentions. But we can't forget who we're serving.
Absolutely. So rounding that out, like we've talked about finding these populations and then how these initiatives are formed. But there's always something I like to bring up is like how we socialize this among peer leaders and the types of metrics and KPIs that we focus on to report. Is it successful? Should we pivot? What are the types of metrics that people should be focused on in these initiatives?
Well, when you sit in the managed care space for 25 years, I've done HEDIS. It's a set of measures for primary and secondary prevention. So primary prevention, we think about screening like breast cancer screening, colorectal cancer screening. Those are specific process measures. And then there's other measures around diabetes, A1C levels, results, eye exam. Those are key metrics for diabetes. And, we take a look at other areas as well, asthma, there's behavioral health measures and pharmacy measures, et cetera. But at the end of the day, it's really about taking a look at the population and looking at the risk stratification and seeing where they're succeeding in terms of rates for those primary and secondary prevention measures that I just mentioned, but also total cost of care. And then let's add the experience side of the members, because again, it gets back to voice of the customer. Are they happy? Are they getting their appointments in timely? It's very concerning for members when they can't even get their annual physical within 30 days because the providers can't get them in till 60 to 90 days, or a specialist for a neurologist, that some areas you have to wait 4 and 6 months to get in. And so think about, if I've got a condition as a member and I'm very concerned about that 4 to 6 months is not soon enough. And so these are the things that we have to think thoughtfully about around. We generate all these beautiful metrics, but what's the metrics most important to the membership that's out there?
When we get down to it, we've talked about the overall scope of identifying the problem, working with populations to find the best way to address it, and then socializing it, understanding what those measures are, and relating our efforts to those measures. And I think there's a tremendous value in that. And there's just one question that we always finish up with, which I'm excited to hear your perspective on it because of the many years in managed care and honestly the compassion and empathy that you have for our most vulnerable. When it comes to the one thing that if you were able to change one thing in how we deliver healthcare in this country, what would that be?
I would like to see that we would address the inequitability of healthcare. Because I would say that when I think about my 4-year-old child experience, I had accessibility, availability, and equitable care to some extent when I hit the United States. No child should go to bed hungry. No child should be without shelter. They need to know that they are cared for, that someone and people care about their welfare beyond just food, water, and shelter, that they have the delivery of healthcare services in the way it was designed to truly provide quality of care of life. I have quality of care of life today, Chris. I want every child, every person in the United States to have that same level of care. And we can do it. We can. It takes everyone, but it takes us communicating. It takes us working in concert. It takes policy development from the federal to the state to the local to the managed care organizations through the partnerships of the healthcare delivery system.
Thank you. And that effort, I mean, a lot of the things that you discussed in terms of being aware of community efforts and connecting those dots in a way that makes sense for a population that you have listened to, it sounds like the beginning of being able to break down those barriers.
Absolutely. And I might do one more value add here. So it's not just about racial, right? It's about sexual orientation, sexual preference, that we have a population that deserves equally that, no matter what age. So it's, health care is not a privilege, it's a right. And it's a right that everyone should have, equitably across the lifespan.
So, Mary, again, thank you very much. And for the people that want to have a dialogue and continue this conversation and better understand how to break down these barriers that you're discussing, what's the best way to get in touch with you?
Well, Health Management Associates, look me up at LinkedIn. It's mwalter@healthmanagement.com. Easy to get a hold of me.
Excellent. We've scratched the surface on health equity, and we'll continue scratching in various different areas. One thing I want to highlight for the folks listening or watching is to continue down that path. If you're looking for some advice and thoughts on driving health equity initiatives and strategies at your own organization, we had a great conversation with Dr. Chriselle Nash, who is the medical director for health equity programs and initiatives at Arkansas Blue Cross Blue Shield. Thank you.